Good morning, everyone. Welcome back to Department of Medicine Grand Rounds. Today, we are excited to have our own Dr. Stephen Liang with us. Dr. Liang received a Bachelor of Arts in Biology and History from Cornell University and went on to earn his medical degree from the University of Maryland School of Medicine. He then completed a combined residency in internal medicine and emergency medicine at University of Maryland Medical Center, where he also served as chief resident. He then later pursued a fellowship in infectious disease here at WashU, where he also earned a Master of Population Health Sciences and then also completed the clinical research, a track within the Clinical Research Training Center. Dr. Liang is triple board certified in internal medicine, emergency medicine, and infectious disease. And you'll see him taking shifts in the emergency department in between his off days from ID consults. In addition, he's currently the medical director for the WashU Occupational Health Services. And in line with this work, today he'll be giving a very timely talk on the emerging infectious diseases, especially measles, given the current outbreak and the most recent avian influenza strain. Please help me welcome Dr. Liang to Grand Rounds.
Okay, good morning. Thanks very much, Dr. Daniel, for that introduction. So today, the title of our talk is going to be Something Old, Something New, Reemerging and Emerging Infectious Diseases in 2005. I have no relevant disclosures. Nevertheless, these are the disclosures for a wound care company that I've done some studies with. So as far as our objectives today, we'll talk a little bit about emerging infectious disease, how they arise, and why it should matter to clinicians. Then we'll talk about two particularly important ones that have reemerged or emerged in the last couple months. So measles and highly pathogenic avian influenza, both of which have headlined our news cycle. So jumping into emerging infectious diseases, what are they? This is an infectious disease that has newly appeared in a population where it has existed, but is rapidly increasing in incidence or geographic range, where it's caused by a category A, B, or C agent. Just to kind of give you a quick note about those A, B, C categories, this is a classification developed by the NIH primarily for biosafety and biosecurity. Obviously, category A are the ones that really catch the news, these high consequence, low incidence pathogens like plague, botulinum, anthrax, and so forth. We are not going to talk about those today. We're going to talk about something far more common in clinical practice. So the story of emerging infectious diseases really kind of revolves around this circle. You'll see many risk factors for them, starting from the bottom here, international travel and commerce. We live in a really small world, and this has been time and time again the conduit for arrival of infectious diseases across continents. Yellow fever and dengue virus both hitched a ride on mosquitoes with the slave trade and ended up in the Americas. That's how they arrived here. A changing ecosystem or microbial adaptation. So you may have heard of a virus called chikungunya virus, which was isolated primarily to Africa for many decades before there was a mutation in that virus that allowed to infect albopictus mosquitoes, which are more aggressive mosquitoes. Those mosquitoes then hitch rides on planes and ships and so forth and end up in South Pacific and then in South America. And you'll recall a couple years ago, there's a very large chikungunya outbreak in South America. The breakdown of public health measures, we see that with Ebola. So war, famine, poverty, lack of political will, Ebola outbreaks have thrived in that setting. Certainly reductions in public health surveillance and prevention. We'll talk about measles today, which is a perfect example of that. Environmental changes, so we live in a warmer and wetter world these days with changes in climate that's allowed for expansion of vectors. So mosquitoes that were previously isolated to the tropical areas have now started moving north. You may remember that malaria for many years was a problem in the United States prior to mosquito eradication. Now that everything is starting to get warmer, mosquitoes are starting to come back, they're starting to migrate north, and we're starting to see malaria cases in the southern United States. Changes in demographics and behavior at the top. So as humans, we expand and urban populations get closer and closer to animal habitats that allows for opportunities for the transmission of viruses, zoonotic viruses from animals to humans. We saw that with SARS, we saw that with MERS and many other viruses. And finally, the intent to harm. Anthrax, the use of anthrax as a biothreat, as a bioweapon, certainly led to an emerging infectious disease in that setting as well. So a very complicated story, but really the underlying thread is one of human travel, human migration, and perhaps more importantly, nature's migration. So my job is to give you an update on measles today, and let's go ahead and proceed with that. So measles, also known as rubiola. This belongs to the family of paramyxoviruses, genus morbillivirus. This is an enveloped RNA virus. And what's really interesting about this virus is that it's been antigenically monotypic. The surface proteins are antigenically monotypic, which means that they have really not changed in their phenotype for ever since the beginning of this virus, which allows us to have a very effective vaccine that has stood the test of time, has remained durable in its response. Measles has been identified for more than 1,000 years. It's first differentiated from smallpox in the 9th century by the Persian physician Rhazes. And you'll see here Rhazes examining his patient with measles, an outbreak here of measles in Japan in the 18th century, certainly at the turn of the 20th century, descriptions of measles to US physicians to look out for that whole body morbilliform rash. We struggled with measles for many decades here in the 20th century before we developed a very effective vaccine and a eradication effort to get rid of it here in the United States. So to take you back, what exactly, the natural history of measles, it typically peaks during the late winter and the spring. It occurs in epidemic cycles. So you'll see here peaks in cases every couple years, large peaks and then troughs and then peaks and troughs and so forth. And basically what's happening here is that you have successive outbreaks of measles that infect a large cohort of susceptible babies and so forth. They all get immune, the cases go down. You get another cohort of babies who don't have immunity. You get another outbreak of measles, and it goes on and on and on, and very cyclical in nature. And you'll see here that with the start of the vaccination efforts in the 60s, those peaks got far lower in number and so forth because of that vaccine. Nevertheless, I want to underscore that measles remains probably the most common infection, one of the most common infectious diseases worldwide, an estimated 10.3 million cases globally, resulting in 107,500 deaths in 2023 alone. So it's the most common vaccine-preventable infectious disease in the world. This just gives you a sense of the geographic spread. It's all over. It's in Asia, it's in Africa, India, South America, and of course here in the United States as well. The leading countries with measles cases in the last 6 months: Yemen, Pakistan, India, Afghanistan, areas where vaccination efforts have been difficult. As far as the current situation of measles in the United States as of last week, we've had 1,024 cases in 31 jurisdictions or states. There have been 14 outbreaks, resulting in 92% of those cases, and there have been 3 deaths, so 2 adults and 2 children and 1 adult. We really didn't see a peak in measles. We haven't really seen a whole lot of measles activities in the last year until the last 3 months or so. This gives you a sense of where exactly we're seeing activity. The largest outbreak of measles has occurred in Texas and New Mexico, associated with a Mennonite community with low vaccination rates. With that Texas outbreak, there have been 722 cases, 92 have been hospitalized, and 2 have died. 2 of those children have died. This gives you a breakdown of the kind of the demographics, primarily a disease that affects the age of 5 to 17, and then some adults as well, you'll be surprised to know. The majority of those cases have involved unvaccinated individuals, but I also want to highlight that we have also had cases in vaccinated individuals. So 1 dose or 2 dose, there have been a handful. And this is not unusual. The typical rate of breakthrough infection or secondary infection or vaccine failure infection is about 0.2%, so it just kind of tracks in line with that. So while the vaccine is highly effective, you still can get measles, but it's going to be far less serious and far less contagious. As far as the transmission, this virus is transmitted from person to person through airborne droplet nuclei as well as respiratory droplets. So aerosols run the full spectrum of size. You have really small ones, you have really large droplets, and so forth. The attack rate is 90%, which means that in a room of 10 people, 9 out of 10 people exposed to a person with measles will come down with measles if they do not have immunity. So highly infectious. Also in line with that, this R0, you probably heard about during the COVID pandemic. That's the number of additional cases or secondary cases generated by each case of measles. So for every individual infected with measles, they can go on to develop 12 to 18 additional cases of measles. So extremely contagious, probably the most contagious infectious disease that we're aware of. People are contagious with measles anywhere from 4 days before the onset of the rash to 4 days after the rash begins. There is thankfully no animal reservoir, no natural animal reservoir for measles, so it's primarily isolated in humans, though it can cause infections in non-human primates as well, but it does not propagate very well in those colonies. As far as the clinical presentation, the incubation period is anywhere from 7 days to 21 days, so you can be asymptomatic for the first week after infection, and then you'll start developing symptoms. If the patient has received immune globulin, which we'll talk about a little bit later for post-exposure prophylaxis, you may even see an incubation period up to 28 days. The reason for this long incubation period has to do with the way the virus infects. So basically, a person gets infected, it infects the lymphocytes, the dendritic cells, and the macrophages, spreads to the blood, you get viremia, and you get seeding of epithelial and endothelial cells and the vast majority of our organs. And then you start having the symptoms at that point. So that immune response to the measles vaccine is really what generates the symptoms, particularly the rash. Also interesting about the measles virus is that in addition to generating that immune response, it can also suppress the immune system. And this is something we're still learning about, this secondary immune amnesia, this immune amnesia that can occur with measles, as well as secondary bacterial infections that people are predisposed as a result of that. So we've gone through our incubation period. The first symptoms, typically a prodrome of these. So fever, and then the 3 C's. You'll remember this from medical school. Cough, coryza or rhinitis, nasal congestion, and conjunctivitis. And you see this child here has the coryza with the runny nose and then the red eyes. They can get photophobia, a lot of lacrimation, and so forth. So these kids look pretty miserable for the most part. You can also have malaise and anorexia as well. After a couple days of that prodrome, folks will then develop an enanthem. So this is a rash internally, right? Koplik spots, you remember, these are gray or blue-white spots that occur on the erythematous base found within the mouth, usually on the buccal mucosa inside the cheeks. So not so much on the palate, but inside the cheeks. Pull those cheeks apart, and you'll actually see these lesions, small white grains of sand on that mucosa. They usually appear about a day or two before the rash, and they persist for a day or two after. It's thought that Koplik spots are pathognomonic. However, they can be seen in other viral infections, including rubella as well as parvovirus B19. And again, you'll see here these grains of salt on a red base within the inner cheek. Those are Koplik spots. Burn those into your mind. After the Koplik spots, then you have the classic rash, this exanthem, which is whole body. Usually starts about 2 to 4 days after the prodrome of the fever, cough, coryza, conjunctivitis. These are erythematous macules and papules that start on the face and the scalp. They migrate downwards towards the neck, down to the chest, and then outwards to the extremities. Over time, this rash becomes confluent and then fades in the same order that it started. It can also have desquamation afterwards, usually seen in the setting of malnutrition or vitamin A deficiency. The rash is typically not itchy. So just a couple images to kind of give you a kind of refresher on what measles look like. One of the first places it starts is it's going to be behind the ears and at the scalp line. You can see here children with the beginning of their measles rashes, as well as on the forehead. Measles can look very different depending on the shade of skin. So in darker pigmented skin, it may not have that classic red appearance to it. Additional children with measles, again highlighting that in darker skin, the measles rash can be hyperpigmented as opposed to erythematous. So we're looking for this whole body rash that proceeds from head to toe, as if someone dumped a pail of red paint on you from head to toe. In adults, the rash looks the same, macular papular in nature. One thing to note about measles is that can also involve the palms and the soles. So our internal residents think about the differential for rashes on palms and soles, in addition to STIs and other different types of infections. You must add measles to that as well with the right epi-risk factors. So to kind of review again, that clinical course, you have that incubation period with no symptoms. You progress to the prodrome with fever, conjunctivitis, coryza, and cough. Then you progress to the rash phase. And then with the rash, it starts fading away and then recover, so that convalescent phase. Symptoms usually improve about 48 hours after the onset of the rash, but recovery can take about a week or 2. So what's the big deal about measles? It really is about the complications, and we haven't seen these complications for a good 50 years or so, so we've forgotten about a lot of the complications with measles. They're more common in young children, so under the age of 5, more common in pregnant women, as well as immunocompromised. The most common complications include otitis media and diarrhea. However, the more feared complications are pneumonia. So 5 to 10% of patients with measles can develop a severe pneumonia, either due to primary viral infection or secondary bacterial infection. Here on the right side, you'll see cases of primary measles viral pneumonia in a child as well as an adult, has that kind of hilar prominence, and then the interstitial kind of very diffuse disease as opposed to unilateral lobar in nature. Patients can also develop keratoconjunctivitis, particularly in the setting of vitamin A deficiency, leading to blindness. And then even more feared are the neurologic complications, and these can be pretty complex. So encephalitis can develop within a couple days of the infection, usually about a 1 in 1,000 cases. The mortality is about 10 to 15% with that. Patients will present with fever, headache, mental status, and so forth. However, there are a couple of other conditions, while a little bit more rare, that are more concerning. So acute disseminated encephalomyelitis, or ADEM, can occur with measles, usually a post-infectious autoimmune process that develops a couple weeks after the initial infection. Patients will, again, fever, mental status change, seizures, and so forth. The mortality with that is about 15 to 20% as well. Less common are the other complications, so measles, inclusion body encephalitis, with progressive neurologic dysfunction, seizures, and so forth. It's rare, occurs about weeks to months later. And then finally, the feared complication is this one that's long-term. So about 7 to 10 years, a very small percentage of patients who had measles, particularly children who were very young when they had measles, can develop this subacute sclerosing panencephalitis with progressive neurologic and behavioral deterioration, uniformly fatal in nature. In terms of the complications with pregnant women, obviously primary pneumonia, as well as maternal death with infection. Also, in addition to that, low birth weight for the fetus, preterm birth, and spontaneous miscarriages. Measles can be transmitted at time of birth from the mother to the child. With immunocompromised patients, the ones at highest risk are those with cell-mediated deficiencies. So patients with HIV, hematologic and solid organ transplants, and so forth. Important to note that in this population of immunocompromised patients, the rash may not even appear, or it may be very mild in nature. These patients will be at higher risk for pneumonia as well as neurologic complications. About 1 in 5 patients with measles will be hospitalized, and about 1 to 3 in 1,000 cases will actually die of measles. So not an insignificant mortality rate. In the developing world, that mortality rate jumps to 1 to 15 in 100 cases, which explains the high mortality that we see worldwide. Most of the deaths are related to respiratory neurologic complications. One thing I think all of us should be aware of is modified measles, particularly among healthcare workers. So this is measles in a person with pre-existing immunity. They've gotten their vaccinations and they've still gotten infected. They're part of that 0.2% that have gotten infected with measles despite the vaccine. This particular form of measles basically takes a little bit longer to develop, and the symptoms are milder, thankfully. So you may have a very, very small rash, very small pinpoint lesions, not very diffuse in nature, start on the head and faces before spread downwards to the chest and outwards to the extremities. The good thing about this is that these patients are less infectious. Obviously, that is because the immune system has seen measles before in the past with that vaccine and is now mounting a quick immune response to that. Probably more historical is another form of measles called atypical measles, and we saw this in individuals who received the inactivated vaccine between 1963 and 1968, now obviously very rare. And it's thought that this is a hypersensitivity reaction after vaccination to measles exposure. These patients have developed high prolonged fevers with a maculopapular rash that started on their extremities and then came more central to the chest and trunk. They also had severe pneumonitis associated with that. These patients typically are particularly infectious because this is a hypersensitivity reaction. So as far as the differential diagnosis, measles looks like a lot of things, and particularly with pediatrics, every rash looks like just about every possible virus you can think of. So I want to give you a couple to just keep on your radar. So roseola, which is caused by HHV6. This is seen in particularly young children. So this is the fever that rashes. That's the way I was taught. So these patients will have a high fever, 40 degrees Celsius or more, and then break out in this whole body rash that starts on the neck and the trunk, goes up to the face and out to the extremities. Another rash you'll recall, erythema infectiosum, which is caused by parvovirus B19, also known as Fifth's disease. This can be seen in both children as well as adults, and it starts with the prodrome, first a fever, coryza, headache, and GI symptoms, and then progresses to that malar rash, or slap cheek appearance to it. So you'll see this child here with the classic flushed cheeks, then spreads to the rest of the body. Reticular rash basically means a lacy-looking rash on the arms and the chest, and then out to the extremities. And then the last rash I want to make you aware of is rubella. So this is the milder form of presentation. It's like a milder form of measles caused by a different virus, obviously, also known as German measles or the 3-day measles, common in children as well as adults. The prodrome is the same: fever, sore throat, conjunctival irritation, headache, then progression to a rash that starts on the head, down to the trunk, out to the extremities. The rash is less intense and shorter in duration than measles, but it can obviously mimic measles very well. Other viruses: chickenpox, enteroviruses, and then all the bacteria that can cause whole body rashes. So group A strep, meningococcus, Rocky Mountain spotted fever, syphilis, we talked about palms and soles involvement, and then non-infectious causes of these whole body rashes. So drug eruptions and Kawasaki's disease, especially we're talking about pediatrics. So this is what you really want to know about. This is where the kind of rubber hits the road. How do we exactly test for measles? Well, the good news is that we've got a pretty good test, RT-PCR, that can be done on either a nasopharyngeal or an oropharyngeal swab. It's got the highest yield early on, so PCR is the way to go. Previously, we also had the serum measles. We still do have this test, the serum measles IgM. This test is going to be positive early on, thinking about IgM versus IgG, that initial immune response with IgM antibodies. This will fade over time. The thing about IgM is that it could be a false negative rate as well as a false positive, significant false positive rate. So it's really kind of fallen out of favor. If we've really kind of favored we're using the RT-PCR. And then finally, the measles IgG, which really does not have a role in acute diagnosis. This basically just tells you if someone has ever had measles any time in their life. However, you can also get an acute and convalescent titer to prove a recent infection of measles. And this figure kind of gives you a sense of why we favor the RT-PCR. Again, positive initially and positive earliest. So when that fever starts and the rash starts, that RT-PCR is going to be positive because of the viremia. Over time, that will decrease. By 21 days, it's going to be reaching kind of the low point of things. In contrast, the IgM peaks as the rash kind of develops here, and then over time starts waning as well, and then the IgG starts later on and then stays positive once that patient has mounted the long-term immune response to measles virus. You've received tons and tons of emails about measles, testing protocols, and so forth, so I will not belabor this. The main thing is if you suspect measles, the first thing you need to do, in addition to the infection prevention measures, are to contact the public health department, discuss the case, get approval for testing. If they do not approve the testing through the public health department, we can also pursue commercial routes. And if you're going to test the patient, you got to get the swab while the patient's in their own room, so don't send them away and have them come back for a swab, just get the sample right away. So as far as the management of measles, for the most part, thankfully, it's supportive. So it's not a whole lot to do, it's just treating a pretty miserable child. However, we talked about those complications to watch out for. So pneumonia and neurologic complications, those patients will require hospitalization in some instances. There is a limited role for vitamin A. That can be either PO or IV. It's a 2-day course of vitamin A. The highest benefit is going to be in children under the age of 2. So there's a Cochrane review done in 2005 and updated in 2011 that showed decreased mortality in hospitalized children under the age of 2, relative risk of 0.21, so significant reduction in that population. In the United States, vitamin A is indicated for hospitalized children. We have also left it to some degree to clinician discretion. The World Health Organization recommends vitamin A for all children, and that's because of the prevalent vitamin A deficiency worldwide. Important to know about vitamin A is that it's not a completely benign vitamin. It can cause liver, bone, CNS, skin, and other complications, as well as birth defects in pregnant and the fetus. There has been some in vitro susceptibility of measles to ribavirin. However, this is not FDA approved, and there are no controlled trials for this, so we should not be using that. So as far as infection prevention, if you suspect measles, the number one thing you must do is mask the patient and isolate the patient immediately. So again, with that high attack rate, that high R0, this patient is going to be highly contagious to others, either in the waiting room or in your clinic or in an emergency department. So you got to get them into a room, preferably an airborne infection isolation room or a negative pressure room. Your PPE is going to consist of things for airborne, so an N95 respirator or a PAPR. Once you've done all these things, you'll notify infection prevention, local public health, and you'll start the testing cascade. Any healthcare provider caring for suspected cases of measles should be immune to measles. So we should really, the vast majority of our healthcare personnel here at the university, I believe about 98% or more are immune to measles, and we're continuing to confirm that rate. The good thing about measles is that there's not a whole lot to do in terms of cleaning or disinfection. The main thing to remember is that in clinic, if you have a patient with suspected measles, after the patient has left that room should be left to settle for about 2 hours to make sure that you have adequate air exchanges to get rid of the virus from the environment. So, post-exposure prophylaxis. This is primarily for non-immune individuals. And basically, there are two things that you can potentially do. If someone does not have a documented history of measles or a negative, let's say non-documented history of measles vaccine, you can offer one of two things. So the MMR vaccine can be given within 72 hours. This provides both protection against infection as well as disease modification should they actually get infected. For these individuals who get the vaccine, there's no quarantine necessary. For those who cannot get that MMR vaccine, so remember, MMR is a live attenuated virus. So your pregnant women, your immunocompromised, your children under 1 cannot get live virus vaccines. Those individuals can get immune globulin, and this is what you give, day to day within the hospital. This is IVIG primarily, though there is also an intramuscular version as well. This can be given within 6 days of the exposure. These patients do need to be quarantined, however, for up to 28 days after their last exposure. And finally, if your non-immune individual is not a candidate for any of these post-exposure prophylaxis regimens, you'll just have to isolate them. They'll quarantine for 21 days for signs of symptoms. So, if only we had a great vaccine for measles. Well, the vaccine was first developed in the 1960s. We do. This is a live attenuated vaccine that was licensed in '63 by Enders et al. This consists of an Edmondson B strain, a very effective but a very reactive vaccine. So the patients who got this also developed fever and modified rash. There was also an inactivated vaccine around that same time that consisted of the same strain, that Edmondson B strain, which also resulted in problems too. So atypical measles, we talked about that hypersensitivity reaction to measles exposure after inactivated vaccine receipt. That is what this is. So we had vaccines starting in '63. In 1968, they fine-tuned that vaccine, made it a little bit milder, a little bit less reactogenic, and that is the vaccine that we've had for the last 60 years, which consists of the Edmondson Enders Meritan strain. This vaccine has not changed in composition in 60 years, and that goes back to the fact that measles is that antigenic monotypic, monotypic, basically the phenotype of the surface proteins has not changed significantly in 60 years. So this vaccine has remained durable and effective for that long. In 1989, we went to a 2-dose schedule, and that was in response to continued outbreaks within the school-age children they showed with 1 dose that the protection was at 93%, with 2 doses up to 97%. That was the rationale for going to 2 doses. However, I do want to show you a couple of additional things that hopefully will reassure you about the vaccine in general. So a Cochrane review performed in 2005, 2012, and then 2020 updated basically showed that with 1 dose, there's 95% protection, with 2 doses, 96% protection. So the general recommendation that the general public, the adult from the general public, should only get 1 additional dose or 1 dose of MMR vaccine, that will be effective is based on this data. So the general person without risk factors can just get by with 1 dose of MMR with high protection. With the advent of widespread vaccination, we saw a 99% reduction in cases to less than 1 case in a million. So this is one of the big success stories of vaccinology as well as infectious disease and public health. In 2000, measles was declared eradicated in the United States, and that's defined as no endemic transmission over a 12-month period. So a highly effective vaccine. The current schedule for measles vaccine for children, the first dose is given between the ages of 12 and 15 months. The second dose at ages 4 to 6 years of age. There are some instances when you can give a dose earlier to children, usually those who are traveling internationally to measles endemic areas, those who have been exposed to measles, those who are going to a school or child care center with an ongoing outbreak. The measles vaccine can be given between 6 to 12 months for those children. However, they oftentimes will still need to get the 2-dose regimen after the age of 1 per the usual schedule. For adults, those who are born before 1957 are presumed to be immune. And that's because of just how contagious this disease and how widespread it was before 57. For those who are vaccinated before 68, we are recommending that they get an additional dose of MMR just in the event that they might have gotten that less effective inactivated vaccine. And for adults without immunity at all, for most people, we're recommending just 1 dose of MMR. For those who are in high-risk populations, so people like you and I, healthcare workers, students attending college, those who are going to be traveling to areas where measles could be more common than here in the United States, they really should get 2 doses of MMR. A couple of other adults who should be considered for that to have at least 2 doses of MMR are persons living with HIV with a preserved immune system, so CD4 greater than 200 or 15%. Family and close contacts of the immunocompromised, so a patient who's going to get a stem cell transplant and so forth, it's probably a good idea for their family members to get vaccinated just to provide that kind of ring protection around that vulnerable individual. And then finally, specific at-risk groups during an outbreak. This is usually guided by the public health department. The contraindications for measles vaccine, because it's a live attenuated vaccine, are going to be those who have had a severe allergy in the past to the MMR, those with severe immunodeficiency defined as any of these conditions, so transplants, HIV with a compromised immune system, et cetera, and finally pregnant women. So United States here, as far as our vaccine coverage, the deeper colors in orange, deeper orange basically signify less than 90% coverage. So certainly a long way to go as far as coverage. Even the lighter shades of orange, that's 90 to 94% coverage. What we're really aiming for is 95% in order to have that quote-unquote herd immunity and protection to measles. And this is pretty in line with what we see here in the state of Missouri. Among our kindergartners in 2016, 2017, we had a 95% coverage rate for measles for the MMR. That's fallen now to 90% as well within our schools here in the area. Many explanations for it. While medical exemptions have remained stable over time, we have seen an increase in religious exemptions, particularly during the COVID pandemic. So definitely a very challenging time all around for public health. And a lot of this has to do with vaccine hesitancy, or I like to think of more vaccine anxiety. It's really, parents and so forth have viable, reasonable concerns about vaccines and so forth, and certainly the press has not helped, and neither has the other folks who like to comment on vaccines. The thing is I think we can do a lot to understand our patients' fears about vaccines, particularly the MMR. One thing to kind of communicate to them is that the risk of an adverse reaction to the MMR vaccine is about 1 to 2 in a million. Now compare that to being injured on your toilet, 1 in 4,000, to being struck by lightning, 1 in 15,000, or dying of a hornet or a wasp sting, which is 1 in 46,000. 1 in a million compared to those things, just part of normal life. So your take-home pay for today for measles, number 1, identify. So understand the vaccine status of your patient and their exposure history. Remember that incubation period of 7 days to 21 days, so fairly long. Remember the progression of disease, that prodrome with the 3 C's and the fever, progressing to the Koplik spots and finally to that whole body rash. Remember the contagious 4 days before to 4 days after the onset of the rash. If you suspect measles, get that patient in a negative pressure room, N95 for you. Inform infection prevention, ID, public health. We have a good test for it, the RT-PCR. There are protocols to get that done. It's all send-out testing, but we can get it done. Usually the turnaround is a couple days. And then finally, supportive care. There is a role for vitamin A. It's going to be children under the age of 2. And finally, we have a safe and highly effective vaccine that's been around for many decades now. All right, deep breath. Let's move on to a different subject. Okay, so we talked about a re-emerging infectious disease. Let's talk about an emerging infectious disease. Highly pathogenic avian influenza H5N1. So the influenza virus belongs to the family of orthomyxoviruses. There are 4 genuses or 4 genera, A, B, C, and D. A and B are the ones that we worry about most with humans because they cause a significant disease. The influenza virus is an enveloped RNA virus. Influenza A in particular has many subtypes. So when you think about that H and N designation, you've heard about several of these variations. Today we're talking about H5N1 that has to do with the surface proteins. So the hemagglutinin protein as well as the neuraminidase, all these are surface proteins that help identify specific subtypes of influenza A. Influenza A is a big deal because of its potential to generate pandemics. And we've lived through a couple of these pandemics even in our lifetimes. This influenza A can infect humans Definitely we see it year to year with seasonal influenza and so forth, but it can also infect other animals, so birds, pigs, and so forth. And that's really where the big concern is arising. So a quick word about avian influenza ecology. So avian influenza, the reservoir is wild birds. So you're generally ducks and geese and so forth. It can be transmitted between these birds through either respiratory secretions or feces and so forth. There are two flavors of avian influenza, your low path and your high path influenza. So H5 and H7 are particularly the ones of concern when it comes to highly pathogenic avian influenza. The big concern about this virus is that it is continuing to evolve through genetic reassortments and mutations, and it's resulted in a significant amount of viral diversity within this family. Today we're talking specifically about high path H5N1. This has been a virus that has caused high morbidity and mortality in poultry. Wild birds are resistant to this virus, though they do carry it from continent to continent. It started first in Asia and then traveled via these migratory wild birds to the Middle East, Europe, and Africa, leading to large poultry outbreaks and die-offs. There were sporadic infections in humans, particularly in 1997, Hong Kong, Guangdong province, and other places in Southeast Asia, with small amounts of human cases and so forth related to zoonotic spillover. So these are persons who are working in poultry, poultry markets and so forth, where they were exposed to infected poultry. And the case fatality rate was particularly high, 50%. And that's the reason why we were worried a lot about these avian influenza viruses for many years, because of the high fatality rate. However, I will say that case fatality rate is biased in the sense that our surveillance basically only catches those with severe disease in the hospital. So we aren't testing everyone who's been exposed and has developed even mild to moderate infection. Nevertheless, a high case fatality rate was seen with these outbreaks of H5N1 in the last 20 years. The transmission for that H5N1 was through a couple different routes, either through a direct contact. You had a pet chicken or something and the chicken coughed in your face or got secretions on your mucous membranes, you were going to get infected. If you worked in an area where surfaces were contaminated with secretions or stool from chickens and poultry, that was another route for infection. And then finally, chickens, if they're flapping their wings, scratching, shaking their heads or so forth, that can potentially lead to brief aerosolization of the virus and then inhalation or inoculation of mucous membranes of humans, resulting in infection. During that time, the infection was primarily related to poultry workers. There was no concern about transmission of disease with either consuming well-cooked meats or handling poultry meat and so forth. Human-human transmission was very rare. It's transmitted primarily by large droplets in direct contact, as well as close unprotected exposure, usually in the hospital setting or in a poultry farm or so forth. So for many years, avian influenza was primarily a problem of poultry and so forth. Then something changed. In 2021, a clade of H5N1, I'm not going to read all the numbers, but this clade of H5N1 we developed in Europe. There was a reassortment that occurred with this virus that allowed it to expand. It traveled by wild birds, migrated to Asia, Africa, and then North America. And this particular clade of H5N1 is now the predominant cause of poultry outbreaks worldwide, as well as wild bird die-offs. So I said before that avian influenza was really not impacting wild birds. Now it is also killing wild birds. That's a signal that it's expanding its host kind of diversity. It's a range of hosts to infect. So this has been a problem since 2022 with large poultry outbreaks. We have lots of poultry farms in neighboring states and so forth, and we've seen this for the last couple of years as well. So this has really raised alarm bells because of the multiple reassortments that have occurred, leading to rapid evolution of H5N1 and an expanded host range. I talked about those wild birds. In addition to birds, it's now infected mammalian species. Most of these are dead infections, meaning that one or two mammals will get it and die. However, the big concern, the big worry is that there will be sustained transmission. We'll have selection for a virus that can transmit on a regular basis within mammals and then also within humans from person to person. So with this continued reassortment and rapid evolution, it's probably just a matter of time. And this is a perfect example. So you remember last year with the dairy cattle and so forth with avian influenza, there was an epizootic that resulted from what they think is a single bird to cow transmission event in Texas that led to this genotype B3.13. What they saw was that cattle were starting to have decreased milk production, unexplained illnesses, It was being transmitted from cattle to cattle, so from cow to cow, and also across states, mostly related to the transport of dairy cattle across state lines to different farms and so forth. So there is, this was an example of sustained transmission within mammals. However, the fatality rate was low. It was thought that these outbreaks were related to contact transmission, so milking procedures, contamination of the equipment, the environment, direct exposure. This particular genotype, B313, was found in high amounts in kind of bovine mammary tissue and so forth, and that's why it was found as well as in the milk of the cow. Cow-to-cow transmission was hypothesized as being related to equipment contamination, as well as environmental contamination. They didn't think that it was airborne or transmitted through migratory birds. However, this virus has also demonstrated the ability, so it jumped from birds to cows, and now it's jumped back into birds as well as to additional mammals. So cats, raccoons have also been identified. We've also had humans. So this is a perfect example of a virus that has changed from birds to mammals. If it gets back into birds, the big concern is that so maybe not this particular genotype of avian influenza, if we have a high mortality avian influenza that affects humans that travels by birds, then you can think about the potential spread of that worldwide. So the current state of H5N1 here in 2021, there have been 70 cases across 13 states. Most of these have been associated with dairy herds, so these are cattle workers, dairy cattle workers, and so forth. Some have been associated with poultry farms and culling, which is the usual transmission pathway for avian influenza. 4 individuals have been hospitalized. There's been 1 death. There's been no sustained human-to-human transmission. So thankfully, cases are coming down, but hopefully I've communicated some of the concerns for worsening for selection of a virus, of an influenza virus that could impact humans. The big worry is pigs. So if you get avian influenza that gets into a pig, you get a human influenza that gets into a pig, they reassort, and then they can basically lead to a large pandemic. This is the geographic distribution, primarily within the Midwest as well as the West Coast. The clinical course of avian influenza, the incubation period is about 3 days, can cause a wide spectrum of disease. Really, we've seen over the last 30 years a shift towards milder disease, so that initial cases that we saw in the 90s with high fatality, that's really changed over time. The current avian influenza presentation is typically going to be conjunctivitis. And this was a case from a dairy worker. I can't remember, that was in California, I believe. They'll get conjunctivitis, they'll have a viral syndrome of fever, cough, myalgias, malaise, headache, GI symptoms. A small number will develop dyspnea, which can progress to viral pneumonia, and then an even smaller subset can have critical illness. So ARDS, renal dysfunction, meningoencephalitis, and multi-organ failure. This was an initial case of H5N1 several years ago with this evolving pneumonia, very diffuse interstitial in nature. So as far as testing for avian influenza, it's a combination of testing of identifying clinical symptoms as well as epi-risk factors. So has this person had close contact, defined as less than 2 meters, unprotected exposure to an infected bird, animal, or animal materials, or an infected person? So we really got to get that history of exposure to infected animals or humans. We have the standard influenza A RT-PCR. This can be obtained from either a nasopharynx or BAL. So the thing about this is that what we use in the hospital, the influenza A, B, RSV, COVID quad test, or the respiratory virus panel, which gives you that whole list of respiratory viruses. If someone has avian influenza, this will identify as influenza A. However, if you suspect, it'll say influenza A non-typable. So if you see that show up on a report and there's concern for avian influenza, that isolate should be sent out to the health department for actual subtyping for H5N1. So that's the only one thing to be aware of. I think that rapid antigen tests, influenza tests, have probably fallen out of favor in most settings. Maybe in a few clinics they still use them. Don't rely on the rapid antigen testing for avian influenza. And as far as the differential diagnosis for avian influenza, it looks like everything else, seasonal influenza and every other respiratory virus. In terms of the management, it is supportive as well. There is a role for antivirals, so oseltamivir can be given. It's better if you get it earlier. It's the same regimen you give for seasonal influenza A for those who are hospitalized. For someone who can't get PO, you can get IV for peramivir. There's been no demonstrated benefit with giving steroids to patients with influenza, avian influenza. For those who've been exposed, post-exposure prophylaxis for avian influenza is also oseltamivir as well, same as the treatment course. There are H5 vaccines that exist. They are not readily available, and they don't work very well. They're poorly immunogenic, so there's still a lot of work to be done on avian influenza vaccines. The current seasonal vaccine will not cover H5N1. When it comes to infection prevention, anytime you suspect it, mask the patient. You need to isolate them. These patients will require both contact as well as airborne isolation. Your PPE will consist of an N95 respirator, gown, gloves, eye protection, the whole deal. I said before that seasonal vaccines don't work against H5N1 at this time. If you suspect a case, talk to infection prevention, public health, and then standard cleaning and disinfection. So our takeaway points for avian influenza, number one, identify. So get that exposure history. Is this a dairy cattle worker, someone who works on a poultry farm, someone who has a backyard poultry farm, or so forth. Think about that incubation period of 3 to 7 days. The symptoms start with conjunctivitis, then progresses viral syndrome. Some people can get pneumonia, some people can get very sick. Isolate the patient, so a negative pressure room, all of the PPE we talked about, talk to all the individuals who need to, IP, ID, public health. You can test for influenza A. Note that the influenza A test that we have here is not going to be specific to H5N1, so it has to be sent out for actual typing and identification of H5N1. And then finally, supportive care and Tamiflu early, give it early. So this brings us full circle back to the story of emerging infectious disease, and hopefully you'll understand now why these two, measles as well as H5N1, kind of reemerged or emerged in the last couple of years. So with measles, international travel and commerce and the breakdown of public health measures, decreased vaccine confidence, and so forth. With H5N1, the dynamic human to animal interface, where we just live close to animals. There's just many opportunities for transmission of viruses. We are not isolated as human beings. And also these host expansion, reservoir expansion that we saw with cattle and so forth. And so my final takeaway points today are that emerging infectious disease, hopefully I've convinced you that they remain highly relevant even in this day and age. We've talked about measles, we talked about avian influenza. I want to also impart that you can't diagnose if you don't consider. So we always talk about emerging infectious disease. We're like, yeah, really interesting, but it's never going to happen here, but you're never going to diagnose if you don't consider it. So know the epi risk factors for it, accept that infectious diseases transcend borders, and keep a one health mindset. So we're all connected, animals, humans, mosquitoes, ticks, everything, it's all connected. So ask lots of questions. My final takeaway, when it comes to both understanding risk factors for emerging infectious diseases as well as hesitancy towards public health and vaccine measures, is to be curious, not judgmental. And then finally, to seek first to understand, then to be understood. We need to listen to our patients, understand their risk factors, understand their concerns, and then we can start addressing emerging infectious diseases. So with that, I'll give a thank you to our leadership, Dr. Fraser, Dr. Powerley, my bosses, Dr. Odedaway, as well as Dr. Shield, Emergency Medicine, and the FPP. Thanks to our emerging infectious disease folks, our faculty, lots of people. It takes an army to fight infectious diseases here in the hospital, in the region, in the country. Thank our physicians, our fellows and residents, APPs. You guys are the front line of healthcare. You see the patients first, you hold the line. To our nurses and staff, you are the backbone of our healthcare infrastructure, and many more. And I think with that, I'm happy to take some questions, and thank you for your time.
Steve, thanks so much. That was a great talk. Talk about holding the front line, ID, medicine, and ED trained and working in both environments, so we're very fortunate. We have time for a few questions.
Yeah.
Do you think that the testing for measles will become easier? It seems like a lot of hoops to jump through, and especially if you're wanting to diagnose it earlier. Do you think that'll become easier?
I think so. I think what we're going to see is like what we saw with COVID. You remember with COVID, the first month or two, we had to go through the public health department, and then the commercial labs started seeing the need for it, started ramping up testing, availability, and access. So I do think that, unfortunately, sometimes it takes a burning platform to get access to testing, so I do think it's going to expand. Yep.
Steve, a lot of people are asking about who should get tested for measles antibody because either people don't remember if they were vaccinated or they have high anxiety, even people who are not in a risk group. And some of the insurance companies now are mailing out directly to patients, get your measles antibody testing because vaccines are available, which seems like an opportunity for them to, generate revenue versus good public health. But could you clarify for people who should get tested for antibodies?
Absolutely. So measles antibody is at IgG. And the thing to know about IgG, even after vaccination, that IgG will be positive initially, but over time it can wane. So you can have someone who's vaccinated and have negative IgG, so a negative antibody. That doesn't mean that they're not immune to measles, it just means that the antibody has waned. You have to remember that second arm of the immune system, the cell-mediated immune system, with your lymphocytes and so forth. Those, when they are, we don't have a readily available way to test cell-mediated immunity, but once those cells start sensing, once they detect measles, they will start ramping up antibody production and so forth, so you can have what's called an anamnestic response to infection. So that IgG, even if it's negative, it's not particularly helpful. If it's positive, great, you've got antibodies, but if it's negative, you've been vaccinated, really that history of vaccination, having received your 2 MMR as a child or 1 MMR as an adult, that actually overrules a titer if the titer is negative. If they have documented history of vaccine, they're good.
Maybe a
James?
good question, but on the subject of measles, are those quarantine recommendations enforceable by the health department or anything like that? Sort of similar to what was going on in some states in COVID?
Exactly. That's a tough one, and it's that one we've struggled.
Can you repeat the question
Yeah.
just for the recording?
Absolutely, sorry about that. So the question was, are quarantine recommendations or regulations, are they enforceable among our patients? And I would say we struggle with that with COVID. We even struggle with that question when it comes to something like Ebola. That question has come up many times here is how much can we do as healthcare to restrict someone from movement outside the hospital if they have Ebola. So with measles, I think it's very touchy. It's something that I would probably defer to public health. They would probably have to talk to state government, attorney general and so forth to see how strongly they want to enforce that. So I don't think that we can necessarily enforce it. We can encourage, we can also give the rationale for why, the reasoning for why it's important not to infect other people. Yeah, thank you.
Steve, Lawrence?
Yeah,
Steve.
Steve. So, do we have any evidence that modified measles ever has severe complications?
Okay, that's a great question. So Steve Lawrence has posed a question whether modified measles has also had severe complications. My understanding is no, but maybe Steve knows a little bit more about than I do. Generally, it's a milder disease. The rationale would be that if the immune system has been primed in the past to recognize measles, that it will effectively ramp up response and shut down the infection. Yes?
Are there confirmed cases in immunocompromised people of disease caused by the vaccine? And if so, what does that look like? Or is that more of a theoretical risk?
So the question is, have there been cases of vaccine-related disease in immunocompromised patients? I believe that there have been, I'm reaching back to some of the literature research I had done, there have been very, very small number of cases with immunocompromised patients. And that, again, is why there is that absolute contraindication for immunocompromised patients not to receive a live attenuated virus. The risk is low, but the risk is present because they don't have a functioning cell-mediated immune system. So it is possible. As far as the presentation, it's probably going to be it will be muted in appearance because they don't have the inflammatory response, that immune response to it. So it could be very vague or absent rash potentially. So you kind of you got to get that history. Are you having, kind of fever? Are you having any of those symptoms? Do you have a mild rash or anything? That's the only way we would actually be able to identify it. As far as complications, we've talked about complications like neurologic and pneumonia and so forth, and the immunocompromised patients would be the ones at risk for developing that. Someone who received a live attenuated measles vaccine theoretically, could have those complications.
Steve, thank you so much.
Thank you very much. Have a great day.